Hello students, welcome to BSN 720 female reproductive condition. So in this class we are going to look at different female reproductive conditions you will come across. This is not a maternity nursing class, so this is med surg, so you're going to see maybe part of these information in your maternity nursing too, but predominantly we're going to look at the abnormalities in the female reproductive system. First of all, infertility. So infertility, what does that mean? Is the inability to achieve pregnancy after 1 year of unprotected sexual intercourse. So if it's 6 months or 3 months, we would not diagnose it as infertility, but it has to be a year. Let's look at the etiology and the pathophysiology which causes it. Predominantly, the cause is ovulation. Problem with ovulation, like people could have anovulatory menstrual cycles, any obstruction in the tube or the fallopian tube, or any abnormalities of the uterus or the cervix. So reasons are anovulation during menstrual cycle, obstruction in the fallopian tube, um, abnormalities in the uterus like endometriosis or fibroids, certain factors of the cervix, all of that could relate to cause of infertility. There are different diagnostic studies. So we study the hormonal level, and when we look at the basal body temperature, that's a good way to tell your hormone levels. So as soon as ovulation happens, um, estrogen level starts to rise or increase. This causes a drop in the basal body temperature, and then after ovulation, the temperature increases. So you would see a little drop and then an increase in temperature, basal body temperature. That means it's an ovulatory cycle. So that's a good way to look at the estrogen levels. Other studies are tubal patency studies. That means a radio-opaque dye is injected into the uterus and the fallopian tubes and to check abnormalities. It's called hysterosalpingogram. It's just a study of the uterus and the fallopian tubes. Postcoital studies are after sexual intercourse between 2 and 12 hours. Usually the fertility clinic will ask couples to go there and also check um, if there is any, like the secretions from the vagina and the cervical region are aspirated, and they look for any abnormalities, or also they look for sperm count and things like that. So those are the studies usually used to diagnose infertility. Management is basically depending on the cause. So if it's related to an ovulation, they might get ovulation medication. If there is any abnormalities in the fallopian tube, we will try to correct that. Other management of infertility is intrauterine insemination or artificial insemination. Then, depending on the technology used, different type of assistive reproductive technologies are used. So it could be in vitro fertilization, could be gift or sift. So depending on the stage of that ovum, if it's just fertilized and implanted into the fallopian tube, then it's uterus or the fallopian tube, then it's called IVF. It's in vitro fertilization. If a gamete is transplanted, then it's called gift. If a zygote, or which is more multiplication of that fertilized ovum happen, and then it is transplanted, then it's called sift. So the name depends on what stage of fertilization we're implanting the ovum. Then also, it causes a lot of physiological and social stress on patients and psychosocial impact on this, because all of these treatments are very expensive, and the couples might be going through a lot of stress during this process. So basic interprofessional management is also supporting the family. As I said before, this is a picture of that ovulatory cycle. When we see that when there is increase in estrogen, you see that there is a drop in the basal body temperature. And then after ovulation, the temperature raises. So this is how a normal cycle look like, an ovulatory cycle look like, versus an anovulatory cycle, there is no much drop or increase in basal body temperature. And if you look at the third picture, the pregnancy one, you see that once the temperature increases, it kind of remain constantly elevated throughout the pregnancy. So that's the basal body temperature, or the amount of estrogen as a result of the estrogen as this change is happening in the body. So question, what is the number of months without pregnancy despite unprotected sexual intercourse is defined as infertility? It is 12 months. Has to be at least 12 months. Another question is, what information would the nurse provide to a patient about tracking basal body temperature? Sorry, excuse me. That means ovulation causes a drop in temperature and then an increase in temperature. So there is a slight drop and then increase in temperature. So that is about infertility. This lesson is like a combination of small topics. So next topic is abortion or termination of pregnancy. Loss or termination of pregnancy before viability is called abortion. It could be spontaneous abortion or induced abortion. What spontaneous abortion means that natural loss of pregnancy as a result of any abnormalities to the fetus. Our body has a natural tendency to expel that pregnancy and then causes spontaneous abortion. Or sometimes people go for intentional or elective termination of pregnancy, that is induced abortion. So those are the two type of abortions we will see. What spontaneous abortion means, that is mostly because of chromosomal abnormalities. Our body itself expels the fetus before 8 weeks of gestation. That is spontaneous abortion. It could be also related to other factors like endocrine abnormalities, any infection, recurrent infection like pelvic inflammatory disease, immunological factors, or like anatomical problems like uterine fibroids or endometriosis, environmental factors. All of this can cause severe uterine cramping and vaginal bleeding and spontaneous abortion. So that's what it means. Induced abortion, we usually give a medication or do a procedure for termination of pregnancy. Usually, if the fetus is about 7 weeks or less than that, injection of medication can induce abortion. Usually, the medication uses methotrexate. Methotrexate is a cytotoxic medication. So we inject that and it causes spontaneous abortion. So combination of methotrexate and misoprostol is what we use for inducing abortion if the fetus is less than or equal to 7 weeks. If it's just like during the second week of missed periods, we can use menstrual evacuations, suction, aspiration, and curettage, dilation and curettage or evacuation is the other procedure, usually used between 10 and 16 weeks. All of this procedure can be used in combination or single, depending on the age of the fetus. So, but after 20 weeks, late abortion is still available in Canada, but only under special circumstances, because it causes a risk to the health of the, if it causes a really big risk to the health of the mother or the fetus, then late abortions are available. So what is our responsibility? Even though it is a miscarriage or an abortion, the person's body go through all the physiological changes which happens during a pregnancy. So it's really important that they get good rest and care. Basically almost the same as that of postpartum care for ladies who have lost their pregnancy. So it's important also that we give them emotional support, because this is maybe a time of grief and sadness for people. Also, look for other symptoms like vaginal bleeding, abdominal cramping, or fever, because there is a good chance that they could develop a pelvic inflammatory disease after that. So, two important things we usually talk to patients are not to use tampons, or if you're using pads, changes quite frequently because the old blood doesn't sit there and cause infection to them. So there is a big risk for infection after abortion. So talk about that and do health teaching on that. What clinical findings usually support the diagnosis of a spontaneous abortion? Let's look at all the symptoms. Vaginal bleeding for sure, raising levels of human HCG, human chorionic gonadotropin. It only increases during pregnancy. So if abortion is happening or miscarriage is happening, this level does not rise. So that's not the answer. Constipation is unrelated, but you will see that the patient has a lot of uterine cramping. And when we do an ultrasound, we won't see the gestational sac. So which is usually seen in a viable pregnancy. So absence of that gestational sac is also a feature that you would see with miscarriage or abortions. Now let's look at the conditions related to menstruation. So it is a collection of symptoms which we're going to discuss. Premenstrual symptoms, dysmenorrhea, abnormal vaginal bleeding, ectopic pregnancies, and all of that. Let's look at the first one, which is the premenstrual symptom. So premenstrual symptom is a complex physical and psychosocial symptoms or psychological symptoms which occur during the luteal phase of menses. What does that mean? You've already learned anatomy and physiology. So the first 14 days of menstrual cycle is the follicular phase where the ovum is developing. And then ovulation happens after the 14 days, and then corpus luteum is released, which is the luteal phase. So the latest theories explaining this premenstrual symptoms are that during the second half or after the first 14 days after ovulation happen, when a woman enters the luteal phase, there is a disruption of serotonin, or there is a reduction in serotonin levels, which causes all these mood swings, anxiety, and all those symptoms. Okay, so you will see that women's health is always not given much importance or significance. We didn't study that really that well to understand all these symptoms better. But usually during the premenstrual stage, we'll have patients or people always complain about breast discomfort, weight gain, abdominal pain, acne. They might eat a lot, headache, mood swings, anxiety, all these symptoms are seen during the luteal phase. And it usually happens during the luteal phase. So it could be either related to a biological trigger or psychosocial factors, neurotransmitters, as I explained, serotonin levels, genetic predisposition, in families people might have like premenstrual symptoms, hormonal imbalance, and also nutritional deficiencies. Nutritional deficiencies really play a big role in these premenstrual symptoms. And it's amazing when we correct some of the nutritional deficiencies, a lot of these symptoms goes away. So usually 20 to 30% of the women who are during their menstrual stage, they could have premenopausal symptoms or premenstrual symptoms. Also, severe cases, they may develop premenstrual dysphoric disorder, which affects 2 to 8% of the people, only a low percentage, but this happens. And usually they have a family history of this mood disorders, depression, history of domestic violence, sexual abuse, all of this are related to that. So one more time to reinforce, which of the following stage does this happen during the luteal phase? So the follicular phase is the first 14 weeks, and then the luteal phase is the second half. And during that luteal phase is there a disruption or drop in the serotonin level, which causes all these symptoms. So how do we care for these people? We can take care of ourselves. This could be applicable not just for your patients, but also for yourself or your loved ones. Doing aerobic exercises can increase the good endorphins in the body. Sometimes medication therapy like prostaglandin inhibitors, like Advil is the common drug, which is a prostaglandin inhibitor, which help with the symptoms. Oral contraceptives in combination can help with the symptoms, diuretics because of weight gain or fluid retention. Um, Doctors nowadays recommend taking SSRIs, especially during the luteal phase. So when you see that SSRIs are used for depression, you see that it's given throughout the year. But if it is used for PMS, we usually recommend patients to take it during the luteal phase. So they don't have to take the SSRI during their follicular phase because they don't really have much symptoms. But after the first 14 days, doctors might recommend to take it for the next 2 weeks until their next period start. And this is like found that researchers has found that there is a lot of symptom relief in women if we do it that way. So it has been effective. That's one of the latest or newer trends in treatment. Nutritional therapy, especially vitamin B12 deficiency, iron and folic acid deficiency, all of this can contribute to increase in PMS or the premenstrual symptoms. Another vitamin which is helpful is magnesium. So sorry, it's an element, it's not a vitamin, but magnesium, especially magnesium glycinate. So if someone is taking magnesium citrate or other combination of magnesium, the glycinate is more helpful in resolving premenstrual symptoms. So those are the things which has been um, in research and been found helpful in treating all these symptoms. Stress management and relaxation is another way of dealing with the premenstrual symptom. And we could tell patients that this is not abnormal, this is a normal process. There is a good physiological explanation for it because there is a drop in serotonin level during that luteal phase, which contribute to all these symptoms. So it's not abnormal, it is a normal process. Next disorder is dysmenorrhea. Dysmenorrhea is abdominal cramping associated with menstrual flow. It could be primary dysmenorrhea without a disease process because of the excessive production of prostaglandin. It could be also secondary dysmenorrhea because of endometriosis or pelvic inflammatory disease or uterine fibroids. Oops. So the nursing management for dysmenorrhea is basically supportive therapy. Um, Prostaglandin inhibitors, those are the NSAIDs, the ibuprofen is found helpful. Other supportive therapy include drinking hot beverages, applying heat to abdomen and back, taking warm bath, etc. Other abnormal vaginal bleeding include oligomenorrhea or absence of menstruation or amenorrhea, or menorrhagia or metrorrhagia. The difference between menorrhagia and metrorrhagia or menorrhagia is increased bleeding during the menstrual cycle. Metrorrhagia is breakthrough bleeding in between the cycles too. So both are excessive bleeding, but the difference is one is with the cycle and metrorrhagia is like excessive breakthrough in between bleeding happening. So that's the difference between the two. Basically, treatment is either medical management or surgical therapy. So, what are the surgical interventions we usually do in patients with abnormal or excessive bleeding is ablation therapy. So, ablation of the viable endometrium. So we either use like really high heat waves, hot fluids, or cryotherapy, which is cold therapy. One of this is used and the endometrium is safely destroyed. So that causes reduction in bleeding. That's the theory behind the surgical therapy or the ablation treatment. Um, Ablation is contraindicated in patients who still wanted to have children. So if they are still planning to have children, ablation is not recommended. Or if there is any abnormalities like any type of cancers, ablation treatment is contraindicated. So those are the main two contraindication of surgical therapy or ablation therapy. Which is excessive use of heat or cold or something to safely destroy the endometrium so it's not causing too much bleeding. So, biggest complication that can arise as a result of this treatment is toxic shock syndrome. As I said before, if they are not allowed to use like tampons or menstrual cup after that procedure because that could all cause stagnation of like old blood, which is a good medium for growth of microorganism, especially like the common organism like streptococcus or something, and then it can cause toxic shock syndrome. So right after this procedure, we always advise patients to watch carefully for high temperature or any symptoms of infection. If there is so excessive amount of bleeding, they have to go back and also check for their blood pressure so that they're not going into toxic shock syndrome. Next topic is ectopic pregnancy. So as the word itself indicates, ectopic means outside. Ectopic pregnancy is implantation of the fertilized ovum outside the uterine cavity. And the majority of that occurs in the fallopian tube. This could be life-threatening if we are not going to carefully treat that. So what happens is that the ovum is always fertilized in the fallopian tube and then it moves into the uterus and get implanted somewhere in the uterus. Instead of that, because of an abnormality of the fallopian tube, either it could be recurrent infections or adhesions or scar tissue, this fertilized ovum get trapped in the fallopian tube and then it implants there and it develops outside the uterus and that causes the ectopic pregnancy. The common cause of people who have recurrent inflammatory diseases or pelvic inflammatory disease, prior ectopic pregnancies, if they already have a IUD and they get pregnant, the chances are it could be ectopic. Progestin only birth control pill failure, all of this can lead to ectopic pregnancies. Usual clinical manifestations are, so they are positive for a pregnancy test, but there is no gestational sac in the uterus. And usually have colicky pain because of the expansion of the fallopian tube. So fallopian tubes or the uterus are just below the diaphragm. And this patient usually complains of shoulder pain and you would think, okay, uterus is in the pelvic cavity. Why would patients have pain in the shoulder? Just because the uterus is just below the diaphragm. So as the uterus or the fallopian tube expands, it causes irritation of the diaphragm. Irritation of the diaphragm causes irritation of the phrenic nerve. Phrenic nerve is the nerve which supplies the diaphragm. Phrenic nerve also has innervation to the shoulder. So it's kind of a radiating pain. The reason it radiates is because it affects the phrenic nerve roots. So patient will have either right or left-sided pain, and then they would say, oh, it's also radiating to my shoulder. And that's very typical for ectopic pregnancy. And that's the reason for that shoulder pain because of it, the irritation of the diaphragm and the irritation of the phrenic nerves. And then they would not have their periods, sometimes have dropping or irregular vaginal bleeding, morning sickness, all the features of pregnancy with a lot of pain and spotting of blood. So, biggest complication of ectopic pregnancy is the rupture of the fallopian tube. If rupture happens, the patient can go into hypovolemic shock. So, it's really, really important while caring for patients with ectopic pregnancy. As a good nurse, you always anticipate that complication. So watch their vital signs very carefully. looking for signs and symptoms of shock. Learn that really well. I might ask questions from that. So another way of, so if it's below or less than 7 weeks, we can use intramuscular methotrexate to treat it or cause induce abortion of that pregnancy. Also provide a lot of emotional support to the family because they might be going through a very tough time. The most common site for ectopic pregnancy is always the fallopian tubes. Now let's look at perimenopause and postmenopause. Perimenopause begins with changes in menstruation. Menopause is the cessation of periods for a complete 1 year. So it has to be cessation for 1 whole year. Usually people between 40 and 58 years, average about 52 years, go through this stage. Clinical manifestation usually associated during perimenopause is like people would start showing that they have irregular periods, vasomotor changes, atrophy, incontinence, breast tenderness, and mood changes. Mood changes are like the biggest problem most of the people would notice. These are all related to the change in hormonal levels. So interprofessional care usually is based on medication therapy. We can provide them with hormone replacement therapy, non-hormonal therapy, especially also look at the nutritional status and correct that. And our biggest role is saying that this is a normal process and helping the patients cope with that stages. So women approaching menopause, you would see that there might be under a lot of stress. They will have fatigue, nutritional deficiency. So it's important that we provide them with or advise them to take nutritional diet, weight control, emotional well-being. All of this is important. Exercise is also really, really important. As the aging happens or as menopause approaches, they will also have changes in their life, right? All their children are grown up now. Their parents might be dependent on them. There could be a possible loss of loved ones. So a lot of life changes also happen during this stage. So it's important that we give that good emotional support. Also, contraception is important if they don't want to get pregnant during that time. It's important that they use contraception even after a period stops for at least 1 year. That's really important. Safe sex practices are important at any age. So all of this should be advised to patients. Biggest physiological change which we can see during this time is osteoporosis. So it's recommended to take calcium and vitamin D. Avoid smoking, alcohol, and excessive caffeine. All of this can lead to bone loss. And you also would see that people start taking like bone building medication like rasedronate or alendronate during this time. Weight bearing exercises are important to tackle with osteoporosis. Bone density testing. This is the time when also women would be asked to do routine mammograms and also like pap test, etc. So all of this is important during that time. Uh, Next condition, let's move to the infections of the lower genital tract. Common infections which we see is because of disruption of the normal flora of the tract. Common condition is candida infection. Candida infection can happen anywhere in the mucous membrane in the mouth, GI tract, or vagina. But most important thing about candida infection is that it usually happens in immunocompromised patients. So because of that reason, not just vaginitis, any candida infection, any recurrent candida infection, public health really recommend to test for HIV if they have recurrent infection which is not responding to treatment, or they develop recurrent infection even after treatment. So usual treatment is antifungal agent, cotrimoxazole is the common medication, fluconazole, all of those are antifungal agents. It could be treated very well with that. But if a person develop recurrent candida infection, it is recommended to do HIV testing. It could be also as a result of other immunocompromised diseases like chronic infection like diabetes. In that case, also the immunity go down and they could have recurrent infection. So it could be anything, but public health really, really recommend to do HIV testing. Other infections is a protozoa called Trichomonas vaginalis. Usually see greenish gray discharge. So before we said candida, we would see cottage cheese like white kind of appearance or discharge. In this case, it's more greenish and gray, and the treatment is metronidazole. Other infections are chlamydia and Neisseria gonorrhea infection. So all of this produces mucopurulent discharge, and antibiotics are given to treat those. That is in general about lower genital tract infection. Let's look at the next condition, which is pelvic inflammatory disease. So in general, what it means is that inflammation or infectious condition of the pelvic cavity. So recurrent infections of the cervix untreated could go upwards and cause infection of the uterus and the fallopian tubes and also cervicitis. And this is called pelvic inflammatory disease. Usual clinical manifestations is abdominal pain, fever, chills, vaginal discharge, etc. Biggest complication of pelvic inflammatory disease is septic shock. Another condition called Fitzhugh-Curtis syndrome, which is usually seen as a complication of pelvic inflammatory disease. What does that mean is that the perihepatic region also get inflamed. So as a result of the pelvic inflammatory disease, a small violin-like strings go from the pelvis and get attached to the liver. So you'll see that PID, untreated or recurrent PIDs, will cause inflammation of the surface of the liver. So if we leave these patients go for liver function tests, that might be normal. There is nothing wrong with the liver function, but it's just around the encapsulated area of the liver or the outermost covering of the liver, or it's called perihepatitis. It's around the liver. So sometimes this inflammation can spread to the liver and cause right upper quadrant pain, and that and sometimes in the ultrasound you would see that there are tiny strings attaching to the liver. So that's called Fitzhugh-Curtis syndrome, and usually manifested as right upper quadrant pain where the liver is. This is a picture of the inflamed uterus. Care usually is antibiotic therapy. So depending on the organism causing the infection, we treat it. Patients should not have any intercourse for at least 3 weeks after the treatment, or once when the treatment is completed. We also give corticosteroids in case of severe inflammation. Analgesics are used for pain. Intravenous hydration is important. Also, any type of sepsis, especially in the pelvic cavity, could go unnoticed and eventually develop into septic shock. So that's we're looking at if this is developing or progressing into sepsis. Application of heat will help to relieve the pain. Bed rest usually in semi-Fowler's position. So when people have inflammation in the pelvic cavity, it is usually recommended to assume Fowler's or semi-Fowler's position, because then it's not spreading all over the pelvic cavity, right? It gets gravity will prevent it from um, spreading to upper areas. So that's the reason usually we ask patients to assume a semi-Fowler's position. Next condition is endometriosis. What it means is that presence of normal endometrial tissue outside the endometrial cavity. So endometrium is the innermost layer of the uterus. So if that endometrial tissue is present anywhere outside that cavity, it's called endometriosis. Clinical manifestation usually are dysmenorrhea or painful menstruation, infertility, pelvic pain, dyspareunia. Dyspareunia means painful sexual intercourse, irregular bleeding. All of these are signs and symptoms. Other manifestation, if it's outside the uterus, it could cause like adhesions, backache, painful bowel movements, dysuria. Also, we see chocolate cysts present outside the uterus. So during menstruation, this endometrial tissue, which is also present outside the uterus, will also start to bleed, and that causes something called chocolate cyst. It's just called chocolate cyst because it's brown in color, bluish brown, black in color. The interprofessional care usually include history collection, laparoscopic examination, pelvic examination, ultrasound, MRIs. Usually we don't treat endometriosis. It's like wait and watch kind of treatment. But if it's severe, then we start other type of treatment like medication therapy, Lupron. These are to reduce the functioning of the endometrium. Anti-inflammatory medication, sometimes oral contraceptives are given. Surgical therapy usually include laparotomy or total removal of the uterus, which is hysterectomy. And if it's done along with the removal of fallopian tube and the ovaries, then it's called hysterectomy with salpingio-oophorectomy. So salpingio stands for the fallopian tubes and oophorectomy is the removal of the ovary. So if we do hysterosalpingio-oophorectomy, means we did remove the uterus, the fallopian tubes, and the ovaries. So this is a picture of endometriosis. You can see that endometrial tissue, which ideally should be present inside the uterus, is present all over the pelvic cavity. Now let's look at the benign tumors of female reproductive system. Common one is leiomyomas. You might also have heard about something called fibroids. The other name for leiomyomas is fibroids, polyps, or other tumors like polycystic ovarian syndrome. So leiomyomas are fibroids or abnormal growth of the myometrium. These are all smooth muscle tumors. That's muscle tumors, so or myomas or myometrium. It grows abnormally and it's called leiomyomas. Most of the cases, the people are asymptomatic. You don't even know that you have a fibroid in your uterus unless you do an ultrasound and randomly find out about it. Or sometimes they have excessive bleeding, then we investigate it further and find out that there's a fibroid and that's causing that excessive bleeding. But if these tumors become larger in size, these are benign tumors, so it doesn't cause any harm. But when it increases in size, it can cause increase in pelvic pressure or push the rectum or the bladder, and then it causes symptoms related to that. Large tumors can be also associated with miscarriages and infertility. So again, here, wait and watch is the treatment. We don't do anything unless it causes any harm to the patient or a patient is symptomatic. If it gets really, really larger, causing excessive bleeding, then might do hysterectomy. Another way is uterine artery embolization because the uterine artery supplies the uterus. So if we embolize that artery, the blood supply to that area is low. That causes reduction in the size of the tumor. Other cancers, which is harmful, which we see in female reproductive system is cervical cancer, endometrial, and ovarian cancer. So first one, cervical cancer. This is the most common female cancer in the world. And usually it's non-invasive cancer, usually see in early 30s, and age advances, they become more aggressive type of cancer, become invasive cancer. So the biggest common cause of cervical cancer is human papillomavirus or HPV. There are multiple varieties of HPV, but the common type which causes cancer is type 16 or 18. Then HIV viruses can also cause cervical cancers because it makes the body immunocompromised, and reduced immunity can cause any type of cancer. So that's why you see cancers associated with HIV viruses too. So other risk factors involved are having multiple sexual partners, using oral contraceptives for a long period. I don't know if you have just saw this Health Canada new warning that oral contraceptives are linked to ovarian and breast cancer, and they just took hormone replacement therapy out of it. The hormone replacement therapy came to with a package warning saying that this could cause cervical and breast cancers, and now they have taken that warning off and then put in oral contraceptive as a carcinogen. So being exposed to medication like diethylstilbestrol can cause cancer, giving birth to many children. Tobacco use, low socioeconomic status is linked to increased cancer. Immunosuppression is another theory of causation of cancer. So all of this are linked to cervical cancers too. This is the cancerous tissue. Clinical manifestation usually asymptomatic during the early stages, so it get undiagnosed. That's why it's important that we go for routine pap tests to see if there is any abnormalities in the cells. Unusual discharges, unusual bleeding, postcoital bleeding, all of these are signs and symptoms. Pain, weight loss, anemia, cachexia, all of these are symptoms of cancer. Diagnostic tests, we usually recommend people to go for screening between 21 and 69. Pap test is usually recommended every 1 to 3 years. And then HPV vaccine is another way of preventing cancer. Other treatment include surgeries, radiation, chemotherapy, depending on the cause or the stage of the cancer. So sometimes if this is diagnosed at an early stage and people want to preserve their fertility, they could go for conization treatment. That means the cervix and part of the cervical canal is removed in the shape of a cone. So the cervix will be removed and then a top portion in the shape of a cone is removed, that type of surgery, so the uterus is preserved, so if they wanted to get have children later in their life, it's possible. Laser treatment, cryosurgery, all of these are localized treatment for non-invasive type of cancer. Other type of cancers which you would see in the endometrial tissue or the female reproductive organ is endometrial or uterine cancers, which is a common gynecological malignancy, and the major risk factor associated is estrogen. So most of them are adenocarcinomas, and the first sign we will see is abnormal uterine bleeding. So that's why it is important that after a year of cessation of periods, if postmenopausal women are having bleeding, it's really, really important that we advise them to check it out to rule out cancer. Now, ovarian cancer is also one of the cancers which is like linked to hormones. Um, and again, it goes undiagnosed because of the earlier vague manifestation. Pain is not an early symptom in case of ovarian cancer. A lot of times people will come to emergency department or to the clinic having like ascites or vague symptoms like that, and then we would say, oh, why does a young 30-year-old lady had ascites for no reason? And then we diagnose and do investigations and find out that there might be an advanced stage of ovarian cancer. So it's kind of sad that it goes always undiagnosed. And there is no screening test for this. So surgical treatment usually include abdominal hysterectomy or removal of the uterus. Um, and sometimes if the cancer is too extended to other organs, then hysterectomy with bilateral salpingo-oophorectomy is done. That means the fallopian tubes and ovaries are also removed. Now, there are different types of hysterectomy. It could be done as an abdominal hysterectomy, laparoscopic hysterectomy, or vaginal hysterectomy. So depending on the area of the disease, the type of hysterectomy is decided. Postoperative care. This is more important for nursing. So always watch for excessive bleeding. And also advise patients not to use the pads more than 8 hours. So this would cause the old pad to harbor infectious organisms and cause infections for the patient. So make sure that they are changing their pads frequently and also looking for any excessive bleeding, especially during the first 8 hours after surgery. Other complications include urinary retention, abdominal distension, and deep vein thrombosis. So always rule out DVTs in those cases of patients, especially those who have pelvic surgeries. They are at higher risk for developing DVTs. Discharge teaching usually include that advise them that now their menstruation is stopped, and also avoid very heavy lifting for the first 6 to 8 weeks after surgery. Usually advised to avoid intercourse for the first 4 to 6 weeks. Some of the ladies who had hysterectomy will say that they have a temporary loss of vaginal sensation, but reassure them that this will come back after a period of time. We also sometimes use internal radiation or brachytherapy, so it's important that we advise that for patients, and also either radium or cesium are used as isotopes and applied using a long handled forceps into the vagina or the cervical cavity, and it is usually left in place for 24 to 72 hours. So what is our role in this is to make sure that that is not dislodged, and also ask the patient that as a result of this local radiation, they'll have some foul smelling discharge post treatment. So this is to be expected and not to worry about that. Sorry, excuse me. Late complications include, as a result of radiation, they could develop fistulas, cystitis, phlebitis, hemorrhage, fibrosis, etc. These are all complications of radiation treatment. So, nursing management, which include assess for leukorrhea, increased vaginal bleeding, any discharges, increase in abdominal pain, etc. Anxiety, pain, body image disturbance, all of those are the potential nursing diagnosis. And we encourage people to participate in treatment decisions, also pain and symptom management, and to recognize and report complications promptly. After surgery, so health promotion is really important after surgery, hysterectomy or removal of the uterus and the fallopian tubes, and teaching about the importance of hygiene and also watching for infection, right? Conditions which you also see in women with lacking pelvic support or lack of the muscle tone is uterine prolapse. So that means downward replacement or displacement of the uterus into the vaginal cavity. This is because of impaired pelvic support. This usually happens with multi-parous women. They had multiple pregnancies or deliveries. They might have a high risk of developing uterine prolapse. So that means outward displacement of the uterus into the vaginal cavity. Other abnormalities are cystocele, which is the anterior wall prolapse, between the vagina and the bladder. It could develop cystocele. Rectocele is the posterior wall prolapse, which is the weakening of the wall between the vagina and the rectum. So those are the things you would see: uterine prolapse, cystocele, and rectocele. Other abnormalities is that if this persists for a long time, fistulas can develop between the vagina and the bladder, which is called the vesicovaginal fistula, or between the rectum and the vagina, and it's called rectovaginal fistula. And mostly management include teaching Kegel's exercise, which is for pelvic support, pre and post-operative care, and discharge treating. There is also a picture of those things like the uterine. You can see that there is first, second, and the third degree or very advanced uterine prolapse. So they usually divide it into, is it grade 1, grade 2, or like first or second or third degree prolapse.